You know, usually when we think about a heartbeat, we picture this really steady, reliable drum constant,
Yeah, yeah,
like thump, thump,
yeah.
thump, thump. It's like a metronome ticking away at about, 1 beat per second, keeping everything in perfect sync.
It is. I mean, it's the universal rhythm of life.
Yeah.
We expect it to stay right in that predictable pocket.
Hmm.
We rarely give it a second thought unless I don't know, sprinting for a bus.
Right, right. But then you look at certain people or certain medical conditions, and that metronome it slows down,
Mhm.
way down, to less than half its normal speed.
Right.
And when you see that, you're forced to ask a really jarring question, like, is this person an elite superhuman athlete?
Yeah.
Or is their heart essentially a ticking time bomb?
And that is the core paradox of a slow heart rate. It is the absolute definition of diagnostic muddy waters.
Yeah.
Because you're looking at the exact same metric on a monitor, but depending entirely on the context, it could represent peak physical perfection
Right.
or a blaring alarm bell for systemic failure.
So today, we are doing a deep dive into figuring out what that resting heart rate actually means. We're pulling from this massive 25-year American Heart Association study, some great stuff from Harvard Health, and comprehensive clinical data from patient.info.
Yeah, it's a lot of ground to cover.
It is. We're basically decoding the hidden language of our pulse.
I know that.
We are moving way beyond the old, 60 to 100 beats per minute rule to understand what the pace of your heart tells you about your present health, your internal wiring, and your long-term trajectory.
Well, to even understand when a slow heart rate is dangerous, we first have to define what it is and look at the sheer mechanics of when it represents, peak human performance.
Right. Let's start with the baseline terminology. The medical term is bradycardia,
Yep.
which comes from the Greek words brades, meaning slow, and cardia, meaning heart.
Makes sense.
And traditionally, it's defined as a resting heart rate under 60 beats per minute. But when you look at extreme physiological examples, that cutoff of 60 feels, I don't know, almost arbitrary.
Oh, completely.
Because elite athletes just casually sit there with resting heart rates in the 30s.
No, that's wild.
The legendary cyclist Miguel Indurain, he had a resting heart rate of 28 beats per minute during his career.
28.
28. And Martin Brady holds the Guinness World Record for the slowest certified heart rate over a minute duration at 27.
Wow.
But wait, Daniel Green was measured in 2014 at a staggering 26 beats per minute.
What's fascinating here is the underlying biological adaptation that makes those numbers possible, because it all comes down to a metric called stroke volume.
Stroke volume, okay.
Right. So through intense, regular cardiovascular conditioning, the heart muscle of an athlete goes through a structural change.
Like it physically changes shape.
Exactly. It becomes stronger, and the left ventricle, which is the main pumping chamber, it actually becomes larger and more elastic.
Okay, let's unpack this. I
Yeah.
kind of like to compare an elite athlete's heart to a massive, highly efficient V8 engine.
Ooh, I like that.
Like, it can idle smoothly at incredibly low RPMs, but still generate a ton of power to keep the car running perfectly, whereas an average unconditioned heart is more like a smaller four-cylinder engine. It literally has to rev higher, like beat faster, just to maintain the exact same cruising speed.
That perfectly captures the mechanics.
Yeah.
Because an athlete's heart has a massive stroke volume, it ejects a much larger amount of blood with every single contraction.
Oh, I see.
It simply doesn't need to work as hard or beat as often to supply the body's metabolic needs while at rest.
In the clinical world, this is called benign sinus bradycardia.
Benign sinus bradycardia.
Right. Benign meaning harmless, and sinus meaning the electrical signal is still originating normally from the heart's natural pacemaker, the sinoatrial node.
Okay, so it's a completely normal rhythm, just very slow.
Exactly. Up to 85% of conditioned athletes have this.
Wait, I have to ask though, if 26 beats per minute is survivable and even healthy for a conditioned athlete like Daniel Green, is there an absolute floor?
What do you mean? Like, is there a physiological point where a heart is just beating too slowly to sustain human consciousness, no matter how big and efficient that V8 engine is?
Well, yeah, there is a functional floor.
Right.
And while it varies by individual, human physiology has strict limits.
Right.
The brain demands a constant, uninterrupted supply of oxygen. As a resting heart rate dips down into the low 30s and 20s, even a massive stroke volume starts to struggle against gravity to perfuse the brain with enough oxygen-rich blood.
So gravity is actually the enemy here.
Exactly. If the brain senses a drop in that critical supply, it initiates a hard reset.
A hard reset.
You experience syncope, which is the medical term for fainting.
Oh, wow.
Yeah, your body physically collapses to a horizontal position, so the heart no longer has to pump against gravity to reach the brain.
That is wild. Fainting is literally the brain overriding the system to save itself by laying you flat. And athletes aren't the only ones who experience natural drops in heart rate. The sources detail a few other completely normal reasons are pulse plummets, like during sleep, where young adults often drop into the 45 to 50 range.
Which is totally normal.
Right. But the one that really caught my eye was respiratory sinus arrhythmia.
Oh, yes. Is a brilliant quirk of our nervous system.
Yeah, explain that one, because I've actually noticed it on my own wearable device sometimes.
So, respiratory sinus arrhythmia is when your heart rate naturally fluctuates in time with your breathing.
Okay.
When you inhale, you are temporarily suppressing the activity of your vagus nerve. Now, the vagus nerve acts like the body's natural brake pedal.
So it slows things down.
Right. So when you suppress it, you lift your foot off the brake and your heart rate slightly increases.
Oh, got it.
And then when you exhale, that vagal activity surges back, pressing the brake again, and your heart rate falls.
That makes so much sense. And speaking of that vagal brake pedal, we have to mention the mammalian diving reflex.
Oh, yeah, absolutely.
Submerging your face in cold water triggers an immediate automatic drop in heart rate.
Yep.
It's an evolutionary survival mechanism designed to aggressively conserve oxygen when we're underwater.
It forces the body to prioritize oxygen delivery to the absolute most critical organs.
The brain and the heart.
Exactly. The brain and the heart itself, while dialing back the supply to everything else.
So an efficient engine idling low is a marvel of human biology. But if we flip the scenario, what if the engine is running slow, not because it's a V8, but because the internal wiring of the car is actually short-circuiting?
That's where things get dangerous. To understand the misfires, we first have to map out a normal heartbeat. It is a beautifully synchronized electrical cascade.
Okay, lay it out for us.
It begins at the sinoatrial node, or the SA node, located in the upper right chamber. Think of the SA node as the master computer.
The natural pacemaker.
Right. It fires an electrical spark that sweeps across the upper chambers, causing them to squeeze blood downward. That electrical signal then falls into a crucial gateway called the atrioventricular node, or the AV node.
And the sources mentioned the AV node acts as a deliberate speed bump,
Yes.
like slowing the signal down for just a fraction of a second so the lower chambers have time to fill up with blood before they pump.
That speed bump is vital. From that AV node, the signal shoots down a specialized pathway called the bundle of His, splits into left and right branches, and terminates in the Purkinje fiber.
Purkinje fiber is
Yeah. These fibers disperse the electrical charge deep into the heavy ventricular muscle, triggering that massive final pump that sends blood out to the entire body.
Okay, so instead of just throwing out medical jargon, let's visualize this as a synchronized city traffic grid.
Sure.
The SA node is the central traffic control tower. The AV node is the main multi-lane bridge connecting the upper city to the lower city.
I like this.
In a healthy heart, traffic flows from the top, crosses the bridge smoothly, and disperses into the lower city perfectly on time. But the clinical sources detail some terrifying ways this grid fails, specifically conditions called AV blocks.
Yeah, AV blocks occur when that main electrical bridge is damaged or obstructed.
How so?
Well, in a first-degree AV block, the electrical impulse from the top of the heart to the bottom is just delayed longer than normal.
So in our traffic grid, there's construction on the bridge, the cars still get across to the lower city, and the final heartbeat happens. It just takes noticeably longer.
Exactly. And the sources note this is often benign. You might not even know you have it.
Right.
But the danger escalates with a second-degree AV block.
Okay.
That's where some impulses from the SA node are completely blocked and never reach the lower chambers. There is a fascinating specific subtype of this called a Mobitz type I, famously known as a Wenckebach block.
Wenckebach block. I saw that word and immediately needed to know how it worked. What is a Wenckebach block actually doing to the heart's rhythm?
So on an electrocardiogram, a Wenckebach block displays a very distinct repeating pattern of progressive fatigue.
Progressive fatigue.
Right. The delay at the AV node gets slightly longer with every single beat.
Oh, man.
The electrical signal takes longer and longer to cross that bridge, until finally an impulse is completely blocked.
So it just drops.
The lower chambers never receive the signal to squeeze, and the heart literally drops a beat, a complete pause.
Wow.
And then, after that dropped beat, the AV node resets itself and the cycle of progressive delay starts all over again.
So it's like the toll booth operators on the bridge get slower and slower with each car until they finally just drop the gate entirely, blocking traffic before waking back up.
That is a perfect way to put it.
That's a skipped beat. And then there is the third-degree AV block.
Yeah, also known as complete heart block. This is a catastrophic grid failure. There is absolutely no electrical communication between the upper chambers and the lower chambers.
It's like the bridge is just gone.
The bridge is entirely washed out.
If the bridge is gone, how does the person survive? Like, how does the lower heart know to pump?
Well, the upper heart continues to beat at a normal pace dictated by the SA node. But because those signals can't cross, the lower ventricles are forced to rely on emergency backup generators.
Backup generator.
Yeah, they're located further down the cellular chain called escape pacemakers.
Escape pacemakers.
But these backup generators are incredibly sluggish. They only produce a wide, inefficient rhythm of maybe 20 to 40 beats per minute.
Oh, that's not enough.
No, it's not. That kind of profound disconnect severely compromises cardiac output and often results in immediate medical emergencies.
Now, the sources reveal it's not just internal wear and tear causing these grid failures. There are bizarre extrinsic threats, outside forces that can physically jam the gears.
Yes, extrinsic factors play a huge role.
We're talking about severe hypothermia slowing cellular function, but also an underactive thyroid, typhoid fever, COVID-19, and famously, Lyme disease.
Lyme disease is a big one.
Which is crazy to me. How on earth does a tick bite stop a human heart?
It comes down to direct physical interference. The bacteria transmitted by the tick bite, Borrelia burgdorferi, can actually infiltrate the tissues of the heart.
Seriously?
Yeah. And when the immune system detects this invasion, it launches an aggressive attack, causing severe localized inflammation.
No, I see where this is going.
Right. If that inflammation happens to swell up right around the AV node, it physically compresses the electrical tissue, creating a barricade that stops the signal from crossing the bridge.
That is terrifyingly logical. The swelling just chokes the bridge.
Exactly.
The sources also highlight drug use. Chronic cocaine abuse is strongly associated with bradycardia.
It is. And the proposed mechanism there is chemical exhaustion.
How does that work?
Over time, chronic cocaine exposure aggressively overstimulates the heart. Eventually, the beta-adrenergic receptors,
The ones that speed things up?
yes, the receptors that tell the heart to speed up, they become desensitized. They essentially go deaf to the body's normal chemical signals. Interestingly, methamphetamine use does not seem to trigger this specific receptor burnout, highlighting just how highly specific these chemical interactions are.
Wait, I'm confused by something else in the pharmacology section. We just established that a low heart rate in an athlete is a massive superpower.
Right.
But millions of people are prescribed beta blockers by their doctors to purposefully slow their heart down, to reduce its workload.
Very common, yes.
So why is a chemically induced slow heart rate potentially a crisis if the number on the monitor is exactly the same as the athlete's?
That's a great question. If we connect this to the bigger picture, it is entirely about dynamic range.
Dynamic range.
Right. The elite athlete with a resting heart rate of 30 can suddenly sprint up a flight of stairs.
Sure.
The moment their muscles demand more oxygen, their healthy SA node instantly fires faster, smoothly ramping their heart rate up to 150.
They have that adaptability.
They have massive adaptability. But a patient heavily medicated on beta blockers, or someone suffering from an aging SA node, suffers from a condition called chronotropic incompetence.
Chronotropic incompetence, meaning they literally lose the ability to change speed.
Yes. Their heart rate is sitting at 45 at rest. But when they try to walk up those same stairs, their heart is chemically or physically blocked from accelerating.
Oh, that sounds awful.
It is. The physical demand for oxygen skyrockets, but the heart stays stubbornly locked at 45 beats per minute.
So they just can't keep up.
The result isn't peak performance. It's crushing fatigue, severe breathlessness, and dizziness. It's never just about the number at rest. It's about the heart's ability to respond to demand.
Which makes me wonder about the long game. Like, if a drug can lock your heart rate and cause problems today, what happens if your baseline is organically creeping up over decades?
It's a huge area of research.
And this brings us to an incredible piece of data in the deep dive. The American Heart Association presented findings from the Aerobic study atherosclerosis risk in communities.
This was a monumental undertaking in cardiovascular research.
Yeah, they tracked the resting heart rates of 5,794 participants over 25 years.
A massive sample size and time frame.
A quarter of a century. The participants averaged 52 years old at the start and 76 years old at the end. That is a massive chunk of a human lifespan to track one single vital sign.
And the baseline trajectory they uncovered was deeply revealing. Nearly 90% of the people in the study maintained a stable or slightly declining resting heart rate as they moved through middle and old age.
Which is surprisingly consistent.
It is. It tells us that for the vast majority of humanity, resting heart rate is a highly conserved, tightly regulated biological metric. It does not naturally fluctuate wildly across the decades.
But the AHA identified the 10%, the danger zones.
Right, the outliers.
The study broke down these atypical patterns. Roughly 9% of people had a heart rate that was stable for years but then started steadily increasing as they aged. About 2% had rates that rose and then fell. And half a percentage point experienced a stable heart rate that suddenly and sharply spiked.
And the outcomes for those groups.
Yeah, what were the actual stakes for that 10%?
The outcomes were stark. After accounting for all other known risk factors, the individuals with progressively increasing resting heart rates over time were 65% more likely to develop heart failure.
65%.
Yes, and 69% more likely to die from any cause compared to the stable group.
65% more likely to develop heart failure just based on a creeping resting pulse.
It's a massive indicator.
The demographics most at risk for these atypical rising patterns were people who smoked, people struggling with obesity, and those with a prior history of heart issues. But biologically, why does a rising heart rate predict a failing heart?
Goes right back to our engine analogy.
Oh, okay.
As a heart muscle is damaged over time, whether from the chronic inflammation of obesity, the vascular damage of smoking, or chronic high blood pressure, it becomes stiff or weak.
So it loses its elasticity.
Exactly. Its stroke volume drops. It can no longer pump as much blood with a single squeeze. So to compensate and keep the body alive, the brain forces the heart to beat faster and faster just to maintain the bare minimum blood flow.
So a creeping resting heart rate over a decade is the sound of an engine quietly struggling to keep up.
That is exactly what it is.
And here's where it gets really interesting. The source is, quote, Dr. Megan Wasfy, a cardiologist at Massachusetts General Hospital, who points out that thanks to wearable tech, humans are checking their heart rates more than at any point in history.
Oh yeah, everyone has a smartwatch now.
We're staring at Apple Watches and Fitbits every single morning. So are these devices just turning us into a society of hypochondriacs panicking over a 2-beat-per-minute shift from Tuesday to Wednesday?
Well, it is a double-edged sword, but Dr. Wasfy's core point is about separating noise from signal.
Okay, what do you mean?
Day-to-day noise, like a minor shift because you slept poorly, fought off a cold, or had an extra espresso, is physiologically meaningless.
So don't panic if it's up a little bit one day.
Right. What the 25-year Aerobic study validates is the macro trend.
The long game.
Exactly.
Yeah.
If your wearable data shows your baseline resting heart rate creeping up from 60 to 65 to 70 steadily over a period of 5 years, that is a glaring, undeniable signal. The long-term trajectory is what matters.
Macro trends, not micro panics.
Precisely.
So let's say someone is looking at their smartwatch and sees that dangerous upward trend over the years. Or on the flip side, they are feeling incredibly dizzy, exhausted, and realize they have pathological bradycardia with a pulse sitting in the 40s.
Okay.
How do we actually fix the wiring? Let's talk interventions.
Well, the clinical priority is always treating the underlying cause first.
Makes sense.
If the slow rhythm is secondary to an external threat, you remove the threat. If it airs at Lyme disease causing that severe inflammation at the AV node, a targeted course of antibiotics kills the bacteria, the inflammation subsides, and the electrical bridge rebuilds itself.
And if it's the thyroid?
If it's an underactive thyroid, you administer synthetic thyroid hormone to speed the metabolism back up.
I saw this incredible detail in the clinical sources regarding infantile bradycardia.
Oh, this is fascinating.
Yeah. Premature babies in the NICU often suffer from apnea and bradycardia spells, essentially because their brain's breathing centers are too underdeveloped to remember to keep a steady rhythm.
That's right.
But the first line of treatment isn't a complex, high-risk drug.
No, it's profoundly simple.
It really is.
The nurses gently rub the baby's back or slightly rock the incubator.
Just a nudge.
Yeah. That basic tactile feedback sends a sensory shock wave up to the brainstem, literally startling the brain into remembering to breathe, which instantly kicks the heart rate back up.
That is just incredible. But obviously for an adult in full-blown acute distress, say someone collapses in the ER in shock, pale, with a heart rate of 30 fading fast, a gentle back rub isn't going to cut it.
No, not at all. In a severe, unstable emergency, medical teams turn to pharmacology.
What's the go-to?
The primary frontline drug is intravenous atropine.
Atropine.
The standard protocol dictates starting with 0.5 milligrams, pushing up to a maximum of 3 milligrams.
So how does atropine actually force the heart to speed up in a crisis?
It is a fascinating mechanism. Atropine specifically binds to and blocks the acetylcholine receptors in the heart.
Acetylcholine, okay.
Right, acetylcholine is the primary chemical messenger used by the vagus nerve to hit the body's brake pedal.
The brake pedal from earlier.
Exactly. By blocking those receptors, atropine essentially cuts the brake lines.
Wow.
It lifts the heavy, calming blanket of the parasympathetic nervous system entirely, allowing the heart's natural adrenaline and sympathetic nervous system to take over and violently drive the heart rate up.
But what if cutting the brake lines with atropine fails?
Then you move to external electrical override.
Shocks.
Yeah, emergency teams use transcutaneous pacing. They apply large adhesive pads to the patient's chest and back, delivering powerful external electrical shocks that literally force the ventricular muscle to contract at a set speed.
Ouch. But if the underlying problem is permanent, say the SA node is completely scarred over and hardened, or there is a permanent third-degree block where the bridge is permanently collapsed, what is the long-term solution?
That requires a mechanical architectural fix. The ultimate technological solution is implanting a permanent dual-chambered pacemaker.
A pacemaker.
The surgeon implants a small generator under the skin of the chest, feeding two tiny electrical leads directly into the heart. One in the upper atrium, one in the lower ventricle.
And it basically bridges the gap.
Yes. The pacemaker becomes the new, flawless AV bridge. It senses when the top of the heart beats, waits the perfect fraction of a second, and then artificially fires the bottom of a heart, bypassing the damaged biological wiring entirely.
Amazing. So what does this all mean for the listener?
Well,
Like if someone is listening to this deep dive and they realize they feel chronically fatigued, maybe a bit lightheaded when they stand up, and they check their pulse to find it sitting quietly in the 40s.
right.
Do they need to drop everything and call an ambulance for an atropine push? Or is this a schedule a normal checkup scenario?
The triage comes down to the severity of the accompanying symptoms.
Okay.
If the bradycardia is paired with crushing chest pain, severe shortness of breath, confusion, or if they have experienced syncope and fainted,
Then call 911.
that is an immediate, life-threatening emergency. Dial 911. But if they just feel generally sluggish, have lower energy, and happen to notice a slow pulse, it absolutely warrants a visit to their primary care doctor or a cardiologist for a 12-lead ECG.
So get it checked, but don't panic.
Exactly. It shouldn't be ignored, but it doesn't require sirens.
It's all highly context dependent. A slow heart rate truly is this incredible dual-natured metric.
It really is.
If you're a dedicated runner and you feel fantastic, a heart rate of 45 is a testament to the massive V8 engine you've built. Celebrate it. But if you're fatigued, dizzy, or if you're looking at your smartwatch and noticing a creeping upward trend over the last 3 to 5 years, your body is trying to tell you that the engine is struggling. You need to talk to a doctor.
Sound advice.
Before we sign off today, I want to bounce a thought off you, kind of merging a few crucial things we've learned from these sources.
Lay on me.
We talked about chronotropic incompetence, how a chemically or physically blocked heart loses its ability to speed up when demand increases.
Right.
And we just looked at the massive ERIC study showing that a resting heart rate that slowly, organically speeds up over decades is a glaring predictor of heart failure and death.
Yep, the engine working too hard.
So in both scenarios, the heart is losing its dynamic range. The baseline gets progressively higher and the ceiling gets progressively lower as the muscle struggles to adapt.
That's a great way to synthesize it.
So as we rely more and more on these smartwatches that passively collect, tens of millions of data points on our pulses every single year, are we looking at a future where cardiologists don't just prescribe pills?
What do you mean?
Like, will they actually prescribe a lifelong heart rate trajectory map?
Oh, that is a profoundly provocative thought.
Right. What if 20 or 30 years from now, The ultimate vital sign isn't a single number scrawled on a paper chart during a rushed annual physical.
Oh, yeah.
What if the gold standard of preventative medicine becomes the customized curve of your heart's pacing across your entire lifespan?
Like an algorithm.
Exactly. A personalized algorithmic map on your phone that instantly flags you the moment you deviate from your 10-year trajectory, catching the very first signs of a Wenckebach block or a failing ventricle before a single physical symptom ever appears.
I mean, if you combine the predictive longitudinal power of that 25-year AHA study with the continuous real-time monitoring of modern wearables, that future isn't just possible, it's highly probable. Oh yeah, we are moving away from taking grainy, isolated snapshots of human health and moving toward filming full-length, high-definition motion pictures of our cardiovascular lives.
A motion picture of the universal rhythm of life. It's wild to think about.
It really is.
Maybe with enough data over enough time, the murky waters of a slowing drumbeat finally start to clear up. Maybe we'll finally be able to look at a pulse of 40 beats per minute and know with absolute algorithmic certainty exactly what kind of engine we're really running.
I think we will get there.
Something for all of you to mull over the next time you glance at your wrist. Thank you for joining us on this exploration of the hidden rhythms of the heart. Keep asking questions, keep looking at the underlying mechanics, and we'll catch you on the next deep dive.